Good evening to you. Welcome to another press conference on COVID-19 in Barbados. This evening, we are actually going to start the discussion on a COVID-19 vaccine, Barbados and the COVID-19 vaccine. This is going to be a two-part series. Today, we are going to give general information and education, answer some of the questions that the public has been asking, consider some of the things that have been floating around social media, which people keep repeating. And then on the next occasion, whether we do it tomorrow or Tuesday, and we will keep you informed as we normally do, we are going to look specifically at a vaccine program in Barbados, and we're going to answer all of the logistical questions and the detailed information that people will want on the rollout of a vaccine in Barbados. But today we want to focus on general information. And to help us do that, I have four guests. I'm going to list them in alphabetical order. There are Dr. Kenneth Connell, clinical pharmacologist with the University of the West Indies, and he is also chairman of the Barbados Drug Formulary. He is an internist, which means that he specializes in internal medicine. He is president of the Heart and Stroke Foundation, and he deals with the area of hypertension in the Global Hearts Program. Also with us, our sister Rosanette Cook, who is a public health nurse and senior health sister at the Sir Winston Scott Polyclinic. She is a registered nurse. She is a midwife. She is a public health nurse, and she has a master's in public health. But she has been dealing with vaccines in Barbados for several years. She is a vaccine specialist in her own right. Dr. Elizabeth Ferdinand is a public health specialist, and she is national co-coordinator of the National COVID-19 Vaccination Campaign. And I say national co-coordinator because tomorrow evening you will meet the second co-coordinator, Major David Clark, who is responsible for the logistics component of the vaccine rollout, whereas Dr. Ferdinand would be responsible for medical and health components. Dr. Ferdinand has been involved as manager of the expanded immunization program in Barbados. She has been the coordinator for health disasters, and for many years she has served on committees and working groups for the World Health Organization. She has acted as Chief Medical Officer of Barbados and served in that capacity for some time. And a very important stakeholder is the Barbados Association of Medical Practitioners, represented this evening by their president, Dr. Linda Williams. She is a medical practitioner in the island, an epidemiologist. She is clinical director of the Barbados National Cancer Study from 2004 to 2007. She assisted with the establishment of the Barbados National Registry for Chronic Non-Communicable Diseases, and she manages her private practice. We don't normally spend so much time sharing the qualifications of our guests, but because of the controversy, the interest, the information and misinformation that is in the marketplace about COVID-19 and the vaccination for COVID-19, I wanted to spend some time this evening sharing with you these qualifications to say these are legitimately well-qualified experts, Barbadians and Caribbean nationals who are able to share information and guide our population in this area. In fact, they have been spearheading many of the government's efforts, particularly Nurse Sister Cook and Dr. Ferdinand. And before we get to our guests, I really want to share some information with you. And that is to let you know that today alone, the compliance team under Mr. Ronald Chapman broke up 4 parties. Yes, people are still having parties, and they're not necessarily wearing their masks, and they're exceeding the number allowed. I'm asked to remind you that it is not legal to have mass gatherings, that this could result in up to 1 year in prison or a fine of up to $50,000. Now, we don't want to criminalize anybody. That is not the intention. We want to protect you, and we want you to protect us and the rest of our country and our communities. We want you to protect your families, and you can't do that if you are not keeping more than 6 feet away from strangers, if you are not washing your hands with soap and water regularly or hand sanitizing, and if you are not wearing your masks, and if you're in mass gatherings. So please, I want to share with you and give you an update on where we are now with our COVID-19 situation in Barbados. It is serious, and therefore those who are breaching the rules are putting everybody else in danger. So, as of yesterday, and I remind you that every day you get the dashboard for the preceding 24 hours. So today's dashboard relates to the period yesterday. There were 33 new cases, 51 people have recovered. The new positives were identified from 693 tests conducted at the Best Dos Santos Public Health Lab. There are now 291 active cases. 16 men and 17 women make up the new cases. And I want to pause here to tell you that over the course of the last couple of days, it struck me that I'm hearing of more men being found COVID positive. And I don't have the specific numbers in front of me, and I apologize. But there are more than 700 men, nearly 800, who have tested positive for COVID since January. And the women, over 400. So you can see that there is a significant gap there. Now, some evening we can get into a discussion as to why it is more men are testing positive. Is it that they're the ones who are out liming still? Is it that they're the ones who feel more invincible? We can have this conversation later on. Of the other 29 cases, there were 26 Barbadians and 3 non-nationals. As you know, the Harrison Point, the Her Majesty's Prison Dodds, the cases are reducing considerably, but to date, Barbados has recorded 1,709 confirmed cases, 709 females and 1,000 males. So this is the updated figure. 1,400 persons have recovered. 18 persons have died from the viral illness, with us recording more than 1 death in the last few days. 18 persons have died. The Public Health Laboratory has now completed 106,949 tests up to February. Those are the latest figures, and they emphasize and they show why it is we really need to comply with this pause. So on this day of national pause, we really are asking people to take time out to think about what they can do differently to protect themselves and each other. Remember that the person who is wearing a mask isn't just protecting themselves, they are protecting you. And when you are wearing a mask, you are not just protecting yourself, you are protecting your loved ones. And now to this evening's discussion on COVID-19 and the COVID-19 vaccine. I'm going to start with Dr. Elizabeth Ferdinand. Dr. Ferdinand, I've already introduced you to the public, and now I want to ask you a number of questions and hope that we can have a discussion around that. So tell us a little bit about your role as national coordinator for the vaccine program. What do you do in that capacity, and what sort of program can we expect? What vaccine are we getting? Are we getting a vaccine?
Good evening, Ambassador, colleagues, and all of Barbados. Yes, let me begin by saying yes, Prime Minister has assured us that we will be getting a vaccine, and we are expecting it later on this week. So, as a national coordinator, what do? I am working very closely with my colleague, Major David Clark from the Defense Force, and our headquarters or operating center is located at the officers' mess at the Defense Force. We were, I would say, appointed or instructed to become national coordinators last Friday by the Prime Minister, and we took up, I won't say residence because we're not sleeping there, but at least we took up our beginning of work on the Saturday morning, last Saturday. So, but I began some work little before that, in that I was helping the ministry to develop our national COVID deployment plan. And it was developed along the lines that PAHO and WHO had outlined for us to do. Because we need to have a plan as a country when we go to the facility like COVAX, or we even go to the manufacturers, we need to have a definite plan so that they know that the country is serious and that they know what they're about. So that was one of the things. And then when Major Clark and I started on Saturday, we started to refine it and to develop an operational plan to actually drill down into the nitty-gritties of what we would be doing. And I think tomorrow when he comes, or at the next program, he will go into a lot more of those details. So he is looking more at like the operational side in the sense of, you know, where are we going to have the sites, vaccination sites, and that sort of thing, and how are we going to move this and that to the location. While I am looking mostly at the teams, who is going to make up the teams, what type of composition are we going to have, who is the leader of the team. And I may tell you that right now our senior health sisters in each of the 9 polyclinics will be the person in charge of each team, and under them they will have other teams. So among that, and you know, looking after little things like syringes and needles and PEPs and that type of thing. So basically that's what I'm doing at the moment.
How many people, you spoke of teams, but how many people roughly do you expect to be deployed in this national exercise?
Ooh, well, we're hoping to have about 30 teams, and each team has about 8 or 9 people in it. So do your mathematics. My brain is a little rusty from that. But so that's 300, 250 people in teams operating out of each of the 9 polyclinics.
What vaccine are we getting?
We are getting an AstraZeneca vaccine. And we're getting, or we're supposed to be getting, 100,000 doses.
Let me ask you one of the questions that has been foremost ventilated on social media globally. Is this vaccine, or is the COVID-19 vaccine suitable for black people?
Well,
black and brown people. I mean, we've heard repeatedly that it's not.
Right. Well, I don't know where that came from. The vaccine is safe and suitable for everyone. Now, there are certain stipulations, of course. We're not doing people under 18, because that's the manufacturing. But as far as race, ethnicity, or sex, nothing, it's safe for everybody. Of course, people who are allergic to its components or people who have severe allergies will not be given the vaccine.
Well, when
But
you say severe allergies, what kinds of allergies? Like if I have sinus problems all the time, or I'm allergic to cotton or to peanuts, does that mean that I can't take it?
depends. If you have to take around an EpiPen with you, or EpiPen, for those who don't know, is a small little gadget that looks like a pen, but it has in it some medicine called adrenaline, which if you get stung by a bee, say, and you're allergic to bees, or you're given some medication that you're allergic to, you can stick yourself with this pen, and it gives you the first dose of adrenaline to get you to medical facility that can look after you. But when we look at the vaccine itself, where trials have been, and phase trials were done, they were done in Brazil, and they're not white. It's done in South Africa, and all of them are not white. So it has been tested in many different ethnic people. So as far as I'm concerned, it is safe for anyone, except those categories that I told you just now, for us to use.
Thank you very much, Dr. Ferdinand. Dr. Connell, let me come to you, please. You are not directly involved in treating COVID patients, but your specialization is pharmacology, the drugs that people take, pharmaceutical drugs. Tell me, please, what is this COVID vaccine and how does it work?
Okay, so thank you, Ambassador, for having me here this evening, especially on Super Bowl Sunday. So the COVID-19 has a cluster of vaccines that are being used. The one mentioned by Dr. Ferdinand has been the Oxford AstraZeneca vaccine, which uses a new platform for vaccines, and that is a vaccine vector or a viral vector or vehicle. The vehicle that's used is a virus called adenovirus, and I'm not going to go into details of how it works, but suffice to say that, like all vaccines, it gives your body the opportunity, your immune system, to learn a part of the virus, which is thought to be critical in causing infection and illness, and allows your immune system to destroy it. When this occurs in an efficient way, people are said to have immunity. And one marker of immunity is called the antibody response. So you'd hear going around people asking about antibody levels and measuring the antibody. The AstraZeneca vaccine does this in a very clever way. I'm going to try to break it down simply for you. Let's suppose the problem with COVID-19, let's consider COVID-19 virus a vehicle. And the problem with this vehicle is that it can knock you down. If you are very ill or you're frail, the chances if you get in an accident to be seriously injured is pretty high. But even if you're fit and you got a good knock by the vehicle, you could get very ill and die as well. So there are several ways of attacking this vehicle. You could either completely destroy the entire vehicle or car, or you could decide, why don't I find some way of just stopping it from moving? And one way of doing that, just as looking at cars and the way they operate, is to destroy the tires. If you destroy the tires, it doesn't really matter how robust this vehicle is, it can't move. And so most of the vaccines, if not all of them that are currently being developed for COVID-19, all seek to destroy the tires, one part of the virus, to prevent it from moving, attaching to cells, and to killing the organism and causing serious illness. The AstraZeneca vaccine places the genetic material for these tires inside a virus that is not very active or is not active, and it gives your immune system the opportunity to develop a response to several of these tires. So the genetic material is in there. Your cells replicate that material to produce these tires. Your immune system looks at it and says, great, here are the tires I'm going to attack. It's not even sure what the virus looks like, but it doesn't matter. Remember, the only thing that matters is that it can destroy the tires, because that's what allows the car to move. And interestingly, The other thing that it does very well, it doesn't just focus on one particular brand of the tire. It says, well, let me also try to see if I can attack tires that are similar. And this is why variants, for instance, that some vaccines may be effective, because your immune system hasn't just learned one particular brand of a tire. It's learned a set or similar sets of tires to destroy. Once you've kind of revved up and you can recognize tires, now then comes along this vehicle, the coronavirus, with its tires. And so what happens? Your immune system attacks it and destroys the virus's ability to move, or in other words, to infect your cells and cause damage. All of the coronavirus vaccines to date, all of them to date, have proven that they're efficacious in reducing severe illness and reducing death and hospitalizations. The AstraZeneca vaccine has shown some early evidence that it might also reduce transmission. This is important because many questions that have come in from the public have been, well, does this vaccine stop me from getting infected with COVID-19? There is no evidence for this. Does this vaccine prevent me from transmitting the virus to someone else? Again, there is no evidence of this either, except for early evidence from the AstraZeneca vaccine. All that the vaccine is therefore doing is preventing you from getting a serious illness, which, although you might say, well, the bar is low there, if you are going to get an infection, you'd rather get the infection but not get seriously ill from it. And just as a side point, most of the vaccines that we have currently available to us do not prevent you from getting the actual illness. They just prevent you from getting very sick from the illness. So the AstraZeneca vaccine is an opportunity for a population that is vaccinated to, one, reduce the likelihood that they will become very ill or die from the vaccine, which is the most important thing right now. And secondly, it appears that it might also decrease the transmission.
So if I can ask a question here, there's a view that the development of these vaccines, the COVID-19 vaccines, have been rushed, and therefore they're not really good.
I can understand that perception because a lot of the media rush during a pandemic focuses on, well, we have a new vaccine and the FDA is trying to get it approved and the scientists are trying to get these things in place. Now, just to put things in perspective, historically, vaccines take a very long time because the old technology used took a long time. So, for instance, the influenza vaccine, way before Linda, my time in medical school, but I guess you would have heard about it, they used egg white, and the virus had to be grown in that egg white, and it took forever. With these new platforms, is what we're going to refer to them as. This doesn't take as long because you're using sophisticated technology. I can say to you that viral vector and viral vehicles and mRNA, for instance, are more than a decade of technology. And it was really just trying to determine, what new virus this technology would be used to counteract. What is the reason for this? Virologists, clinical pharmacologists, other scientists quite rightfully identified that we were likely to face pandemics, and we don't have the time to build up technology. So the technology had to be there, approved, and waiting for a pandemic. And here we have a pandemic, and therefore it was able then to be used quite quickly then to fine-tune for the COVID-19 virus.
This might be a good point at which Dr. Ferdinand wants to make a comment.
Yes, I just wanted to follow up on what you said, Dr. Connell, is that there are working groups, as I told you before, at WHO, and one such working group is the Pandemic Influenza Preparedness Working Group, of which I happen to be a member. And in that group, we look at, of course, influenza, not COVID. But what happens is that we've been able to negotiate with countries to share any new viruses that come along, so that in the case of China, where this particular virus is supposed to have originated, it was shared as early as possible with WHO. We are also in relationships with the WHO laboratories, special laboratories that receive then these viral materials from the different countries. And after that, there is also a sharing from the laboratories with the manufacturers. So everything is a win-win situation where the group tries to get viruses quickly and early. They share it then with the laboratories that are qualified in the WHO system, and those laboratories also share them with the manufacturers of vaccines. And so that is one of the reasons why we were being so quick to be able to develop these vaccines for this new disease. In addition to what you already said, Dr. Connell, about the technology being much more advanced than it was years ago.
Thank you, doctors. Sister Cook, this is a good time to bring you in, please. You have been involved in vaccination and vaccine delivery in Barbados for some time. Tell us a little bit about your background working with vaccines in Barbados. I know you've been involved with PAHO and the vaccines that PAHO imports into not just Barbados, but into the region.
Good afternoon, Ambassador. Good afternoon to the press. Good afternoon, Barbados. Right. My involvement with the vaccine, I was started being involved with the vaccine from as early as 2003. But then I really took over in 2011 when I went to the Winston Scott Polyclinic then. And I've had that task from 2011 up to this day in terms of being responsible for the vaccines. So that is what we do on a daily basis, on a weekly basis. We are actually responsible for overseeing the vaccines to some extent when they're around, when they arrive.
This is the first time we're having a nurse on the program, and you are play a significant, a pivotal role in the vaccine program and nationally, generally, and will play a significant role in the coming COVID vaccine program. I know that there has been a lot of talk about the special storage temperatures that are needed for these vaccines. I believe that you're responsible for making sure that the vaccine that comes into Barbados is properly stored.
Yes, please. The Ministry of Health has a very adequate storage facility for the vaccines, and generally that facility is monitored every day in regards to the temperatures so that we make sure the temperatures are up to date. Vaccines are usually stored at temperatures on average +2 to +8 degrees Celsius, and that is how we monitor our vaccines. We make sure that they remain viable, we make sure that they remain in good condition, so then that they can be dispersed to the public. So yes, that is what we do, making sure that those vaccines maintain that specific temperature, and that temperature is maintained from the point where the vaccines are, what we call the cold chain, from the point where the vaccines are manufactured, where the process of transporting them right away until they get to Barbados, right away until they're stored in the Ministry of Health facility, and then right to the point up to inoculation of the patients.
And once the vaccine gets in here, you have that responsibility for ensuring its correct storage.
Yes, we do. Like I said, stored at the Ministry of Health storage facility.
In the event that there were a power outage, would the vaccine be compromised?
No. The Ministry of Health also has backup generators, which are checked, which are serviced frequently. So, and also in the event that there's a power outage, there's an alarm set that we will get a notification early before anything can go wrong. And like I said, the generator generally kicks in, so we don't have a problem with that. That is not a real problem that we have.
Who is going to be administering these vaccines?
The public health nurses, we are the ones who have been responsible and are still responsible for the administration of the vaccines. So the public health nurses within each clinic, what will happen is that we make arrangements to have it done in the clinic, but we also arrange with out in the community, whether we use the schools, whether we use the social centers, whatever the case may be. And this is something that we've been doing for years in terms of vaccine campaigns. So basically, this is like just a continuation of what we're accustomed to doing.
So a couple more questions.
Yes.
I don't normally come to the polyclinic, so the polyclinic has no records for me. But, you know, I am an elderly person, or I have NCDs and I want to get vaccinated. How does the polyclinic even know that I exist and that I want my vaccination?
Okay, so we use a system, an electronic system referred to as MedData. That MedData system was set up from the Electoral and Boundaries Commission. So one of the things that happen within that system, we have the names of every person registered at the Electoral and Boundaries Commission. So as long as you can give us your ID number, we can actually pull you up in the system. Even although you may not have been a patient at the clinic, I can still actually find your name. And the way the system operates is that even if you're seen, let me just say at Randall Phillips, and you go to Morris Bayer, we can still see you and follow you through with the system. So therefore, it doesn't matter where you go, you can still have access to your vaccine, because they said we can still see your record once you've started. And even if you're not started, we register you, and then again, if you go elsewhere, you can be followed through.
It's been said, or it is being said, that persons who take the vaccine, I'm going to ask you two questions, persons who take the vaccine can expect their hands to hurt, bad feels, and to get sick. Is this true? And what can a person expect if they come to get the vaccine, or when they get the vaccine?
So generally, I would say to persons, when you get a vaccine, you're getting a stick with a needle. So it is expected that there might be a little pain at the injection site, maybe a little soreness, maybe a little redness. But then we advise you in terms of the injection site, please don't rub it, please don't squeeze it, please don't put anything on the injection site. In the event that you should get a fever, because some people do get a mild fever sometimes, we just advise you to take 2 Panadols every 4 to 6 hours and you will be fine. However, if the fever should progress longer than 2 days, for instance, then we would ask you to return to the clinic to us.
So these are my last 2 questions for you now. I'm coming to get my vaccine. I may have to stand up in a line for a while. Do I have a good breakfast or a good meal before I get there, or do I come with an empty stomach? How do I prepare for this vaccine?
Right. So you can have your breakfast, your meal as usual. That's not a problem. Just bring yourself and we'll be fine. But they say you don't have to not eat to get a vaccine. You don't have to eat to get a vaccine either. Once you're in good condition, once you're in good health generally, you can still get your vaccines. And we target those persons, the high-risk persons, those with the chronic diseases, the elderly. Those are the persons that we want to target in the initial stages too. But you can get your vaccines.
You are a nurse, you are a midwife, you are a mother. Would you give this vaccine to your children?
Of
Would
course.
you take it?
Of course, yes, I would give the vaccine to my children. I have a daughter who's actually asking me for the vaccine. She's not even to age for it, but as soon as she gets to 18, she will definitely get her vaccine. And yes, I've also said to my staff, I'm going to be the first person to take the vaccine.
Dr. Ferdinand, Sister Cook spoke very eloquently just now, but she did refer to people having some, a little bit of malaise or something when they get the shot. How are y'all dealing with that in the clinical setting? I come in, I get my injection, and I start to get bad feels or palpitations. What happens?
Okay, well, there's a process through which you're going to go through. And I'll run through that in a minute, but let me specifically answer your question. At the end, after you've had your vaccine, you will go to what I loosely say is the recovery area. So you will be sitting there and you have to stay at least 15 minutes. And we will observe you, and you will observe yourself, of course. And once everything is okay, you will be allowed to leave. But you're not going to just come in, get a stick, and go out. So prepare yourself. You're going to have a little wait, because when you come in, you're going to be sanitized and temperature taken. But that's the routine now everywhere you go. You're going to have that. You might have a few words, little talk on what the vaccine is and what you're getting and what to expect. And then you will go to the register, the medical clerk who is going to register you, as Mrs. Cook has just said. And then you will go on to the nurse and have your injection and then on to the recovery area, where we're introducing this new aspect which we've not had before. It's a certain new app that we're working on, trying to get it fully developed, where you can have your information that you've already entered, but updated, and you will be able to get your vaccination card or certification electronically. We are going to give you a hard copy of your vaccination record, but we're working on this app to be able then to give you it electronically. So that is the process. So you're not going to run off right away. So if you don't eat before you come, bring along something, especially for the elderly. Bring along a little something in your bag so that you can munch on it through the process.
Thank you very much, Dr. Ferdinand. The president of BAMP, Dr. Linda Williams, an epidemiologist. She is also a member of the COVID communications unit as an important stakeholder in this whole process. Dr. Williams, you are here with us by Zoom. Welcome. Let me start by asking you, what is the role of BAMP as an important national stakeholder in this entire process? I heard you in previous broadcasts on the television saying, we are your doctors. What are our doctors doing? What role are they playing in this? Dr. Williams, you may be muted, and we do want to hear you.
Thank you, Ambassador, for having me on the program. Barbados Association of Medical Practitioners represents the doctors in both the public and the private sector. And so doctors who work in the hospital, the polyclinics, as well as in private clinics are all members of BAMP. And we have a wide variety of persons there who are from general practice, family practice, emergency medicine, pulmonology, internal medicine, all the surgical specialties, public health, epidemiology, every form of specialty and every form of medicine that is practiced in Barbados is represented in our organization. We are hoping, of course, to get all doctors to be a member of BAMP, but it is not like the lawyers in the Bar Association where they are required to become members by law. BAMP has been, from the beginning, very vocal, and I'm sure you would have heard us in several fronts, making our case with respect to COVID-19 in Barbados. We have reached the place now where we're talking about vaccines and in getting the population vaccinated. And we're also going to be playing a role in this. We have been asked to supply or to use our medical knowledge and expertise in becoming part of the teams that will be set up to be vaccinating the population. And several of our doctors, almost 50 of our doctors, have signed up to assist with the teams and also for the monitoring of persons who were immediately vaccinated after the vaccinations have been given. So we support the effort to vaccinate the population at this time because it's very important that we have good uptake of the vaccine. Barbados has a good history of people being vaccinated. Many vaccine preventable diseases have been eradicated here because of our good history. Most children are vaccinated before their 5th birthday and before their entry into primary school. And they would have received vaccines for measles, mumps, rubella, etc. With this pandemic, we have had to fight not only against COVID-19, but also against the infodemic, which is a lot of fake news and false information has been put out there about what vaccines are and what they do and how they affect the population. And so as the medical fraternity of this nation, we want to speak out against that infodemic also, and we want to put the correct information, the scientific information out there. BAMP has a task force, a COVID-19 task force, and we have looked at the science every day, and we look at what is relevant and what is coming out and put out information. So we want to encourage the population to listen carefully. We have several updates on many different aspects of COVID-19, including vaccination. And we believe that the AstraZeneca vaccine is a good vaccine for our population at this time.
Thank you, Dr. Williams. Let me ask you some questions, please, that are of relevance to our particular demographics and our disease burden. I'm a pregnant woman. Well, I'm not pregnant, but should a pregnant woman take this vaccine? Would it be safe for her?
Okay, so for pregnancies and for people who have, as Dr. Ferdinand said, allergic reactions, so there is a hesitancy because obviously you can't trial a vaccine in pregnant people. So although you're having phase 3 trials, we don't trial vaccines necessarily in the pregnant. So at this time, we will try to vaccinate as much as the rest of the population as possible to protect those who are in pregnancy and with those with conditions who cannot take the vaccine. And that's the concept of herd immunity, having as many people as vaccinated as possible to slow down the transmission so that those who should not be taking the vaccine would also be protected.
What about those who have cancer, stroke, pressure, sugar, heart conditions? Is the vaccine safe for them? Is it recommended? For whom is it contraindicated?
Right. So it is safe for them. In fact, the people who have the chronic diseases, the people who have the poorly controlled diabetes, the poorly controlled hypertension, the strokes, and those are the very people that we want to vaccinate because they are not at higher risk of getting COVID-19, but they're at higher risk of getting severe illness when they are infected with COVID-19. So that's the population that we want to vaccinate, the people who have the non-communicable diseases that you mentioned. And there is no contraindication in people who have those conditions that you mentioned.
Well, asthmatics. We have a lot of people with asthma.
So again, those are the people that are at risk of having severe disease and the people that you want to take up the vaccine so that they are prevented against having severe disease. The vaccine, as Dr. Connell said, doesn't stop you from becoming infected with COVID-19, which is why it's really important to continue the public health practices, mask wearing, social distancing, hand washing, even after you've received the vaccine. But what the vaccine does, it prevents you from getting severe COVID illness, which might require the use of supplementary oxygen or even ventilation. And so that's what we want to prevent. We want to prevent the burden of people who become very ill. So the elderly and those with non-communicable diseases, particularly lung diseases, COPD, etc., those are the ones who we want to take the vaccine because they are more vulnerable.
When doctors speak of persons being immunocompromised, what exactly does that mean, and what does that mean in the context of a vaccination?
Okay, so you can be immunocompromised because you have a primary condition, which means that you are born with a reason why your immune system doesn't work as well as other people's. So there are some conditions where children have faulty immune systems and they don't mount good responses to when they come into contact with germs. And so those are very rare, those primary immune diseases. But then you have mostly secondary immunocompromise, and that may be caused, for example, if you have HIV and AIDS, then those are diseases that attack the immune system and cause the immune system to break down. Also, some drugs cause immune suppression. So you have immune suppression because you may be taking a medication, you may be taking chemotherapy, or you may be taking some active immune suppressant, such as the disease-modifying anti-rheumatic drugs in people with lupus and those kind of rheumatoid arthritis conditions. And those medications that they're taking may also suppress the immune system. You also have immunocompromise in some chronic conditions, for example, renal disease, where you may be on dialysis, etc. And in those people, they have secondary immunocompromise as well. So all of these conditions mean that the person's immune response will not be as robust as a person who is not immunocompromised. So if these people get the vaccine, they may not mount as vigorous an immune response as a person who is not immunocompromised. And so therefore, the only risk to them is not the vaccine, which does not contain any part of the COVID-19 virus, but the risk to them is that if they meet COVID-19, to use Dr. Connell's analogy, they may not be able to punch out the car wheels. So that's why it's really important for everyone else to get vaccinated. Because if we vaccinate as many people as possible, then the risk of transmission to those who can't mount as vigorous immune response becomes less, because the transmission of the virus in the population becomes less.
I just have two more questions for you before we go back to Dr. Connell, who I know wants to jump in. Dr. Williams, does this virus or the vaccination have anything to do with 5G? And does the vaccination have a microchip which is being implanted into people so that Bill Gates can know more about us than he already does?
Thank you for those questions, Ambassador. What I will say is that there's a lot of information on the internet that people follow. And in the recent years, it actually followed a study that was on MMR and autism, where the author claimed that if you took MMR vaccine, that the children were getting autism. The author was found to have completely fabricated that paper, and he has been removed. His medical license to practice has been removed. But that spawned a whole tsunami of anti-vaccination movement. And that also resulted in a spike in measles, mumps, and rubella in those countries in which that anti-vaccine sentiment grew. And that anti-vaccine sentiment has grown and grown since then to incorporate all kinds of theories about why vaccines are unsafe, why vaccines are implanting microchips, and whether or not somebody may be using it as part of a campaign to control us. None of these things are true. And vaccines have kept our nation and all the nations of the world safe for many decades. Polio was once a major problem. And it is not a problem that anyone who is under the age of 70 or 80 in Barbados can even remember a single case of polio. And the reason why we can't remember it is because of a vaccine campaign to eradicate polio, which was rolled out worldwide in the 50s and 60s. And so because of that, we don't see these diseases anymore. We hope that one day COVID will be something like that it'll be something that we have so suppressed the transmission that even though it's still there, we just deal with it by getting, maybe annual or semi-annual. We don't know the period yet or how long the immunity will be produced for. So we hope annual vaccine for COVID, and that will then just make the whole severe disease that we see now go away.
Thank you. I'm going to give two quick questions and hope for quick responses from Dr. Connell before we move to the ladies and gentlemen of the press. We have a full press corps with us this evening. Dr. Connell, there are two questions here. Should a person get a PCR test before being administered the vaccine? And if not, what would be the risk involved if the person were unknowingly positive and asymptomatic and took the vaccine? That's the first question. And the second one was, there we go. What about the different strains going around? How does a vaccine designed for one strain make an impact when different strains exist? Those are the two questions for Dr. Connell, and then we open the floor to our press corps.
Thank you, Ambassador. I will be brief. First, I want to give clear, definitive responses to two comments made earlier. One is pregnancy. If you are pregnant and you are offered or you're eligible for this vaccine, you should have a discussion with your obstetrician, who will then weigh the benefit risk at an individual level. This is not something that can be done in a public space like this. With respect to your particular pregnancy, your exposure at home, and then decide whether you should go ahead and take the vaccine or not. And the second one is always is quite common as well, and that is fever. I wouldn't exactly characterize fever as an adverse drug reaction to a vaccine. It is an expected reaction to vaccination. And all of us, whether we measure it, or we can feel whether we think we were warm or not, we will all have a fever, most of us after a vaccine. And as Sister Cook said, this can be easily treated with paracetamol taken on a continuous basis as directed by your healthcare provider. And in direct response to your question, it's interesting, the asymptomatic positive patient who for COVID-19 and whether they should go ahead and take the AstraZeneca vaccine or any vaccine for that matter. The guidance so far has not been against taking the vaccine, except in people who are symptomatic. And that isn't for obvious reasons. If you are symptomatic, your immune system is currently engaged in fighting a virus, and it probably might not be the wisest thing to take a vaccine. Anyone who is ill, you have to also understand that your body is not just an immune system. Several other systems are involved in the fight against whatever infection or whatever illness is involved. For instance, if you have symptoms for heart failure, if you have just had a stroke, these acute events or sudden events are never a good time to take a vaccine, because your body as a whole is managing an urgency or an emergency. And your last question relates to variants, which I think is quite interesting as well, because variants are going to emerge. And let me just state here, the longer the population takes to be vaccinated, the more time is available for variants to emerge. So if there's one positive population benefit that all of us can get besides herd immunity, is to stop the emergence of variants, since all of us will have some type of immunity. Remember, I said that the response of your immune system is quite clever and sophisticated. It spots the tire, but it doesn't only say, let me just learn how to attack this tire, because this is the only possible tire that this vehicle will have. It kind of looks at other variants to that tire, and it says, well, we may get a change in the thread of this tire, and therefore, but I still want to be able to attack it because it still can fit on this vehicle and cause some problems. This is exactly what happens with COVID-19. The mutations that have occurred in the spike proteins representing the tires are captured under some vaccines for that very reason. Now, of course, you might get a mutation to the point where it is outside of that spectrum of tires that your immune system recognizes, and that is a problem then, because the vaccine does not cover that. So that's my response to the asymptomatic positive patient. This person should be immunized because PCR testing is not recommended before taking your COVID-19 vaccine. However, if you are symptomatic, and not even just for COVID-19, for anything, your healthcare professional, and certainly Dr. Ferdinand will attest to this, in the screening prior to vaccination, you will be asked some basic questions about your general health. If you're feeling very ill at that time, that's never a good time to take any vaccine, whether it's COVID-19 or not.
Thank you, Dr. Connell. Dr. Ferdinand, I have a question for you. What about people over 65? Should they take it or shouldn't they?
Yes, they're the ones we really need to target, because it's been shown that the majority of people who get the disease and progress then to have serious disease are those not only with chronic diseases, but the elderly. So we are going to be trying to vaccinate as many of the elderly as possible.
Thank you. I have to tell you that I just received a WhatsApp message from a Bajan over and away who said that they had absolutely no intention of taking the vaccine until they heard this presentation this evening, that they've been very impressed with the quality of our professionals. So let me thank all of you. Ladies and gentlemen of the press, we have joining us by Zoom Barry Aline of The Nation newspaper, Ian Bourne of Bajan Reporter, Kareem Smith of Barbados Today, David Ellis and Akil Lovell of Starcom. I was going to say ladies and gentlemen, but I think we have a full complement of male press professionals this evening. The floor is open and our panelists will receive your questions, please.
Good afternoon, everyone. My question is for Dr. Ferdinand.
Go ahead, please.
Dr. Ferdinand, this is Barry Allen from The Nation. Good evening. In every country, there's a level of anti-vaccine sentiment, and this has nothing to do with Pfizer. Persons are anti-vaccine for ideological reasons, for other reasons. Before you guys roll out vaccinations of AstraZeneca in Barbados, is there any way you plan to have dialogue with the public in terms of getting more Barbadians who do not want to take a vaccine to actually believe in the inoculation process and actually increase the amount of persons who eventually will be vaccinated?
Well, this is the beginning of it. Okay, so we're going to intensify these type of talks. We're going to be doing some social media promotions. Even we've already developed some frequently asked questions, not only for the public, but also for the doctors or medical practitioners, and these will be rolled out. We have a very short period of time, and yes, it's a challenge, but we're going to try our best, okay? And just hope that they come around. Now, if they have any serious questions and they really feel, look, I'm not taking this thing, or I don't want my grandmother to take it, or what's not, they need to ask their medical practitioner for advice. The president is here. She has endorsed it on behalf of her membership, and we in the, well, I'm retired again, forget to tell you, but the Ministry of Health and all their practitioners are in the polyclinics and in the other institutions, and if they have a doctor, they should ask a question, okay? And that's what what I'm saying. I'm hoping that the media and the other media avenues that we're going to be following will be seen by every social class and age group, because we don't just want the elderly, we want everyone to know, and we want the younger people to encourage the older people to come and get their vaccine. So I hope I've answered what you want, Barry.
Thank you, Doctor. One quick question for Dr. Connell. Dr. Connell, with regard to AstraZeneca specifically, after inoculation, how soon will the person develop immunity? And what is the shelf life of AstraZeneca? How long would a person remain immune after being vaccinated?
Okay, thanks, Barry. So I've never heard shelf life referred to in that way. How long would they remain immune? The shelf life for the actual drug in its container is not known. It hasn't been stipulated by the manufacturers. How long the individual remains immune now, again, we don't know. And if you're getting at the fact that could this mean that we will be vaccinated again next year or have to be vaccinated 2 years from now, we simply do not know. Every vaccine campaign has to involve surveillance, not just for side effects, but in this case, we will have to measure immunity over a period of time. It appears that data from people who have actually been infected has already been showing that some of their levels of immunity are falling with time. But again, and this is important, there is a more robust immune response if you've had a vaccine than if you're just recovering from COVID-19. So even if you are recovered, you should still get the vaccine because you want a really robust immune response to protect you for a longer period of time. And your first question was AstraZeneca as well. I missed it. What was the first question? Your mic is muted.
It was about the shelf life, doctor. Thank you.
It was the shelf life, right? Okay, thank you. So I've answered both questions.
Just to give 2 bits of information, the FAQs, frequently asked questions, we are doing 2 e-brochures. When I say we, the COVID communications unit, BAMP is doing their own, and I know that other agencies are also working on FAQs and other literature that will be made available to the public. As members of the public are aware, the COVID communications unit, we sent out our material by WhatsApp, by radio, on television, by every possible media that persons can consume information. So our e-brochures will be available tomorrow evening for the public, and we are doing an e-brochure for health professionals, and we are doing a second e-brochure for the general public, because clearly they would have different kinds of questions. Some would be similar, but they would have different kinds of focus in their questions, and that's what we have attempted to address. I believe that Queen Elizabeth Hospital might be doing one for their own staff and their stakeholders. In relation, Barry, Mr. Aline, to your question as to vaccine resistance and vaccine acceptance, I can tell you that we have, the Ministry of Health and Wellness has conducted a survey to determine what is the level of vaccine resistance in Barbados. I have to apologize because I actually wrote a message today from somebody who was engaged in that process to find out what the answer was, and I forgot to hit send. So when I looked just now to see what they had responded, I'm sorry. Nurse Cook, Sister Cook, you wanted to say something. Perhaps you can advise me on my memory.
Good afternoon again. I just wanted to respond to Barry Allen in terms of communication with the public. What I'm finding is that even although we've not officially sent out some of the communication, persons are actually calling or actually coming to the clinic to speak to the public health nurses. And I've had situations where I've had at least 3 persons who come to me, to ask, Sister Cook, do I take this vaccine? Sister Cook, what this vaccine is about. So I find when they can still get that kind of information, even on a one-on-one basis, that I find persons are actually willing, and I have persons ready and actually waiting, just want to know when can they have the vaccine. So the communication is still going out there, even if on a one-on-one basis.
Sister Cook, you vaccinate. I've come up and I hear, I ain't taking it. Tell me something that will make me take it.
All right. Again, if you say you're not taking it, we try to explain the benefits to you, the benefits of having the vaccine, the benefits of protecting your family, because remember, it's not only about you, the individual, but you're going back home to your family, you're going back home to your elderly grandmother, you're going back home to your children. So we try to explain the benefits to you, the pros and cons. I even give you the minor effects that you might have. And I find more often than not, by the time you get that information, once persons are comfortable with you, because I find that is very important, being comfortable. And once that person is comfortable with that one-on-one situation, like I said, you do get persons saying, okay, I'm coming for my vaccine. And I actually have that, where persons are waiting to get their vaccines.
Really, thank you. Ladies and gentlemen of the press, we continue with your questions.
Yes, hi.
Region
Ian
reporter.
Bourne here.
Yes.
Yes, please. Thank you. I wanted to find out whether asymptomatic or not, people who have successfully completed isolation, that they had COVID and they've come out and they're back into society again, do they require a vaccine, or do they already have sufficient antibodies? The other question I wanted to find out, it was actually based on something that Dr. Ferdinand had said when she was speaking about public education. People that do come back from isolation and go out into the public, there's a fear from other people. Is there going to be a public education campaign to make sure that people who came out of isolation are not treated as pariahs?
Well, I know the question wasn't asked of me, but having had COVID, I can tell you that the stigmatization is extensive and real. I mean, if I share some experiences with you, I think that some people would be shocked. Yes, and because I am acutely aware of that, and we are now having more families who are having loved ones come back home into the houses, and they have had COVID. We are having people who have to go back into their work environment, and they have had COVID, and it's known. This is a small society. We've had families who have lost members to COVID, and there's tremendous stigmatization and lack of information. For instance, only last week, I had COVID now nearly a year ago. I went to a business place and I went my temperature was taken, the normal protocols, and I left and I went off to do my business, and I could hear a conversation taking place, and the security guard was saying, I didn't want to get too close to she because she had it. I know, I was so nervous, and so on and so forth. And, this is a real concern, and I understood his concern, and I came back and I said to him, you don't have to fear people who have had COVID. It's the people who have not had, particularly people who are close to you, that you need to be careful with. So yes, I do plan to do a public education on that specifically, and a program on stigmatization. But the truth is that COVID covers so many health and socioeconomic areas, whether it is labor, the elderly, the vulnerable, social stigmatization, mental health. There are a huge number of questions, and every press conference I have been trying to deal with a particular area of focus, and we will continue to do that. So sorry for my interjection. The others can pick up on their answers.
No, I'm very glad you did. But I was going to say that thank you, Ian, for raising that, because it is something that we know has to be done. But there were so many other priorities that we had to go forward with. But it will come. And I mean, if you cast your mind back when we worked together years ago with the HIV/AIDS, that was the same thing when we had the stigma at the beginning. But gradually, as it percolates into the community and people say, oh, well, that's my brother, my sister had it, and so it is going to be like that for a little while, but I think it will gradually fade away, and we definitely do need to include it in your media press briefings.
Yes, thank you.
I want to respond to this, Mr. Bourne. So, because I think very clear messages have to be given to the public on these public health issues. One is that if you have tested positive, if you have recovered from COVID-19, you still need to take the vaccine. There is no evidence that the immunity from having had this disease is protective enough to even stop you from getting it again, and also to stop you from getting very ill. So to be very clear, if you have recovered from COVID-19, so you're not actively ill, you should be vaccinated. The second point is that there's an important clock that is ticking. One is the fact that this virus is in an environment and mutating. And the longer that this environment or the population takes to be immunized, the more variants will emerge. And the more likely that the variant that emerges will be resistant to a vaccine. And quite often, some people may sit back and say, well, I'm going to give it a year or 2 years and see what happens. Then I'll take the vaccine. You are not doing the population any good by delaying your immunization. You are just making it more susceptible to variants.
Younger people, because the fear has been, or the view is, well, only old people then, and then people that got a lot of diseases already. We good. Well, not we, but people younger than I am, because we have observed that the greatest resistance is in the 35 to 49 age cohort. I just got back my answer, that there is high acceptance amongst the population for willingness to take the vaccine, with the greatest degree of resistance being seen in the 35 to 49 age cohort.
That is not surprising either.
Yeah.
Simply because the 35 to 49 age cohort has now been seasoned into vaccine fear and hesitancy, and therefore they're less likely to want to take a vaccine. They also aren't old enough to really think, well, are also not old enough to think, I'm very ill, so I really do need to take this vaccine, and they're more willing to wait another decade or two. So this age group is a higher risk because we don't want to get vaccinated for two reasons. We don't think we're old enough, And also we have some hesitancy because we know of the history of vaccines. Sorry, Linda, I think I interrupted you.
To all panelists, there's a question coming in. So, yeah, Dr. Williams, you answer to it. I have a question coming in. Can the vaccine itself kill you? That's the question.
Okay, so let me I was going to jump in where Dr. Connell was talking about the 35 to 49-year-old age group. We have grown up in an era or a setting where we have not known childhood mortality in the way that perhaps the older generation knew, when children died of mumps and rubella and measles and polio and diphtheria and so forth. We have come up without knowing these diseases. But the reason we have not known these diseases is because of vaccines. And so this particular age group now has come up where in a setting where hesitancy or distrust or mistrust in vaccines is higher because they have not known eradication of diseases from vaccines. Now, the question is asked, can you die from the vaccine? Let me just state, first of all, that these vaccines are not using the actual COVID-19 virus. The AstraZeneca vaccine, as Dr. Connell explained, it takes a virus that cannot cause infection in a human and attaches a part of the COVID-19 particle to it. So it does not have the COVID-19 virus in it. So it cannot reactivate inside your body and give you COVID-19 and allow you to die from that. With any drug, with any medication, there's always the possibility, in people who have a large number of allergies particularly, there's always the possibility of an allergic reaction. That is why we have doctors on the teams, doctors on site, and even we hope to have somewhere that you can report your symptoms to or report to your doctor should you have any adverse effects within the first 3 days of receiving the vaccine. But vaccines do not normally cause death. And that's why we have phase 3 clinical trials, to make sure that they have that safety, that when you roll out a vaccine, that the risk of the disease is far, far greater. The risk of dying from the disease, is far, far greater than the risk of dying from the vaccine. So this vaccine, when we say vaccines are safe and efficacious, we mean that they are safe, they are not going to cause major harmful effects, including the harmful effect of death, and that they are not going to harm you in any significant way that will cause you to lose your life.
We'll wait further questions from the media.
Hi, good evening. AQ Level Starcom Network News. My question is directed to Dr. Kenneth Connell. Dr. Connell, government is aiming to have about 60 to 70% of the population vaccinated to ensure herd immunity. But given the hesitancy we've seen so far from people willing to take the vaccine, how do you see the country achieving this target?
Okay, so first of all, I would say that I don't think we've carried out a scientifically robust enough study to say that there's that level of vaccine hesitancy, that the uptake of the vaccine is not going to be what we want. In fact, Barbados, compared to other Caribbean countries, has had quite high uptake of vaccines in previous years. So there's nothing to suggest that the COVID-19 vaccine will be any different. I do take the point that there has to be aggressive public education, because remember, we are dealing with generations that are exposed to a lot of media, and therefore they have heard a lot of fake news about 5G and all the other things, and therefore they have legitimate concerns. And with them, you also have generations that know the history of vaccines and always will carry that mistrust, and that is nothing that should be kind of dismissed either. So therefore, there has to be aggressive public health education for the uptake to be there. But you're absolutely correct. It makes no sense if only 20 or 30% of the population takes up this vaccine, because the whole herd immunity concept is lost. And the point that I want to really drive home is you then will have another population mutating the population of viruses of COVID-19, and therefore variants will evolve, because viruses are smart. They want to live just like us. The only way they can do so is to mutate and find more clever ways of invading or bypassing our immune system. So we can expect, if we do not get vaccinated within a timely fashion, and we don't know what that time is, then as a population, we are more at risk for these variants.
Can I
Make the
just,
point
jump
that
in
the
here,
survey
Ambassador?
has not found that there is high hesitancy. That has been an assumption that the survey now suggests is not exactly accurate. Dr. Williams.
Yeah, just to mention the variants, somebody had asked earlier if we have different strains. What we have is different variants of the virus right now. If you have sufficient mutations, then you would get a completely different strain. But right now we have a UK variant, South African variant, Brazilian variant, etc. And what these variants are is that they are more transmissible. They're more readily passed from one person to the other. Now, so far, what we know is that the AstraZeneca vaccine seems to be doing fairly well against the UK variant. Against other variants, there's still not enough conclusive evidence. But one good thing, as Dr. Connell had mentioned earlier, is that because of the robust scientific technology that now exists, making changes or tweaking the vaccines so that they can address the variants is something that could be done much more readily now than could have been done years ago. So, for example, the influenza vaccine varies from influenza virus, varies from year to year. And what epidemiologists and other types of public health specialists do is that they predict the type of variation, and virologists predict the type of variation that is going to occur. And they make the new vaccine for each coming year based on those predictions. And so that we expect will probably happen with COVID-19 as well, that we will alter the vaccine based on the prediction of variations or the pattern of variation that we see emerging. But it's really very early in this process to be able to tell how COVID-19 is going to evolve.
David Ellis from Starcom. I have two questions, one for Dr. Williams, one for Dr. Connell. Dr. Williams, as an epidemiologist, what can you tell us about the positivity rate in Barbados at the moment, and to what extent does that make the need for this vaccine all the more urgent? And to Dr. Connell, South Africa today said it would temporarily halt a planned rollout of AstraZeneca COVID-19 vaccine after a small clinical trial found that it doesn't appear to protect recipients against mild and moderate illness from a fast-spreading new strain of the coronavirus first detected in the country. We assume that's a reference to the South African variant. Though that has not been identified here in Barbados yet, that's only because we are unaware of any tests that have been done for it. And along with that, we also have the Brazilian variant. In those circumstances, how would you react to the news that South Africa has taken this particular position on the AstraZeneca rollout?
Linda, do you want to go?
So okay, I can go first. So thank you, Mr. Ellis, for excellent questions. The positivity rate. Okay, so the positivity rate would be a calculation, a metric that can be looked at. It's a good metric to look at in terms of measuring how well we're doing. And the positivity rate is the number of the proportion of the positive proportion of people positive out of the tests that are done on a day-to-day basis. We have estimated that the positivity rate for Barbados varies between 4.2 and 9.2%. We have been as high as 9.2% from our estimates, okay? But it's hovering right now between 4.2 and 9.2%, which suggests that we have a very active phase going on now in our pandemic. We really want to see that positivity rate fall to less than 1.2, 1.5%. If we have a high positivity rate, we maintain a high positivity rate between 9 and 10%. It means that almost 10% of the samples tested on a day-to-day basis are reflecting positive cases. And it's a metric of how the pandemic is progressing. So we need to work on that by decreasing transmission. And that's why vaccination is important, I think your second question was to Dr. Connell.
That's correct.
Sure. So I'll go ahead. So yes, I've seen the news report. I haven't seen the data specifically, but from the news report, just to recap, the South African government has halted the vaccination of the AstraZeneca vaccine because obviously the variant in South Africa is a South African variant, and the vaccine hasn't been shown to be as effective against it, or not effective. Now, without seeing the data, I would say that makes sense. If you have a variant in your country that is not covered by the vaccine that is in your country, then it makes sense to use another vaccine which might cover that variant. However, you have to kind of counterbalance that with the idea and situated in Barbados that, okay, so we don't have the South African variant here, as you correctly said, we haven't tested, so we don't know. But we do have a population without any or with very little immunity. And using this fact, we then know that this population is not only at risk of developing severe illness and all the complications of COVID-19 and being infected, but the population also has the risk of helping to create more variants. So at a population level, we have even more responsibility to immunize with a vaccine that is effective in our setting. And therefore, it doesn't negate the South African study, whatever the data is showing there, but it also says that countries, this is a country-specific response as well, but it is also a global response. And if other countries likewise say, well, we're not going to use AstraZeneca, although the dominant strain in that particular country is not the South African virus, then that doesn't make any sense, because what will happen is that more variants will emerge, which will of course then be resistant as well. So direct response to your question, it does not negate the fact that the AstraZeneca vaccine should be used in other territories where there's been thought to be some response still possible.
Coming in, as a woman that does take medication, I could mix up the vaccine and my medicine.
Well, I thought you were going to ask about mix up the vaccines, because that's a bit more controversial. But
Dr. Connell spares the controversy today. Let's just stick with the question that this lady is asking.
So that's easier. So if you're taking medication, can you take the vaccine? The answer is yes. All of your chronic disease medications, your blood pressure medication. Remember, we said in an earlier program, it is important that your blood pressure, your blood sugar, all your other chronic conditions are controlled, because it reduces the likelihood that you will have a severe outcome if you were to contract COVID-19. Therefore, you continue all of your medications. Now, if you have, as some of the panelists have said, a history of a severe allergic reaction. Now, this has to be distinguished, because some people out there are saying, well, I have allergies, I get hay fever, is this vaccine? Of course, you should take the vaccine. This is not a contraindication to vaccine. If you have a severe allergic reaction to vaccines, or if you're known to have severe allergic reactions, you should discuss with your healthcare worker whether your vaccine is adequate or appropriate for you, because it may just mean having something like adrenaline or EpiPen there, maybe some hydrocortisone or some equipment there and drugs available to dampen that severe allergic response. So continue your medication, and only those with severe allergies, which by the way does not include asthma. Severe allergies may present with reason, but if you are asthmatic, you should also take the vaccine.
Kenneth, I just want to point out to that lady that the vaccine is not a tablet, it is an injection. So it's not that you're going to mix it up with your tablets, because you're getting it as an intramuscular injection, a needle, as Ms. Cook said, in the muscle.
What does that mean? An intramuscular injection, Dr. Williams? Where does one get this injection?
So usually in the deltoid muscle, which is in the arm. Okay, I think most people would have taken children at some point in time to get a vaccine. So it's usually given in the arm, and that's why you can get a bit of a sore arm afterwards. And that just tells you that the vaccine is doing what it's supposed to do. It's working, and that soreness will eventually go away. So it's not a tablet, it's an injection.
Okay.
Question, Dr. Connell. In your professional opinion, do you believe countries should actually purchase more than one brand of vaccine in their efforts to actually reach herd immunity? We've chosen AstraZeneca. Should we also think about Moderna and Pfizer and or?
I think countries should respond sensibly in the best interests of their citizens and choose whatever vaccine is available that has been shown to be efficacious and safe. If countries can afford to purchase several different types of vaccines, then that is possible, and it certainly would allow for more options. It does not mean that if a country can only afford or only has available at its disposal one particular brand, whether it's AstraZeneca, Pfizer, Moderna, it doesn't mean that having less choice means that this puts the population at a higher risk of complications or not even developing immunity. So in direct response to your question, countries need to make that decision based on their own health systems and what they can afford.
There's a question here from Loop News. I'm going to language it differently to the way that it is asked. Doctors, you and Sister Cook, you have spoken to the possibility of a post-vaccination temperature. How long does that temperature last? And are you giving people vaccination certificates so that they can carry them to establishments if their temperature is showing high? Do you understand? So they're asking, how long does that last? And does it last so long that you need a certificate to say to people, well, my temperature is high because I just got vaccinated, or I got vaccinated a day or two ago?
Sorry. Good afternoon again. In response to that question, I would say usually the temperature might last just about 48 hours, 24, 48 hours. But at the same time, the temperature is not that elevated. It's usually not that elevated that you would have a problem when you go to establishment or so. But generally within 24 to 48 hours. And once you take your paracetamol also, as we suggest, that temperature is usually taken care of from there.
Remember I said that
because the temperature from COVID-19 doesn't respond very well to paracetamol, whereas from a vaccine fever, you will get a response from paracetamol.
Not sure if this is the right forum, but I am nevertheless curious about the assertion from Dr. Fauci about double masking. I didn't know if anybody in the panel could address that, or if the Ministry of Health and Wellness have to examine that suggestion. Using two masks instead of one.
Yes, what I can say at this time is that we haven't changed our masking policy, but the reason behind the double masking was the presence of new variants. That's where the suggestion was made, that because of the presence of new variants, people should wear two masks, a mask like what Sister Cook is wearing, the non-surgical type mask, as well as a cloth mask. But that suggestion has not been rolled out for Barbados, and so I would defer to the Ministry of Health and Wellness if we're going to change our masking policy. At present, it is that you should wear a mask properly and correctly covering nose and mouth whenever you are within 6 feet of another person, and that the surgical mask, the N95, etc., be reserved for those who are in the healthcare profession. I think the reason for that here would mostly be not that we shouldn't have better masking for the whole population, but we don't have infinite resources. And so we have to use the resources or leave the resources such as the N95s for the healthcare profession. But if double masking is something that every intervention that we have to study to see its effect. So we can't just pick it up because it is said elsewhere. We have to look at the scientific data and see if that is something that can be a recommendation, and therefore they would make the recommendation following that.
Williams, do you have a mask to hand?
I certainly could. Yes.
I'm going to ask you, I know you did a video for CCU that was very well received. I'm going to ask you, please, if you could demonstrate before we close the press conference, what is the correct way to wear a mask?
Okay.
Do you want this advice from Art?
So if you want it now,
Please.
I have a cloth mask to hand, okay? And so one of the things you should first do, I'm going to use this, is that you should sanitize your hands. I don't know if you can see. You should sanitize your hands properly before you put on your mask, okay? And after sanitizing your hands, you should hold your mask by the ear loops, put it over nose and mouth, and cover fully. Remember that the mask is the area where you're exposed to COVID-19. And so you don't want to touch the front of the mask. So when you're going to remove your masks as well, you should also sanitize and remove from the ear loops rather than touching the front of the mask repeatedly, because you're going to assume that the front of the mask is the contaminated area. If you have to carry your mask, I suggest to people that they put it in a Ziploc bag or something like that, so that when they take it out, they can take it out by the ear loops again and put it on. And so that's the way that masks should be taken off and put on.
Dr. Ferdinand, with the plan now to vaccinate, will persons need to go to their doctors to be guided as to whether they should get the vaccination? Do they have to get their doctor's permission?
I said that they could ask their doctor if they're hesitant or if they're reluctant to have the vaccine and they want, extra thoughts on it, extra guidance. But no, once they fall into the categories, they're welcome to come and have it. They don't need to have permission.
Sister Cook, this will be the largest mass vaccination campaign that we have ever done. Are you and the nurses ready?
Yes, we are. We've actually started preparing even on Friday in terms of those persons who are even concerned about I may have an allergic reaction or such like it. We have actually prepared our emergency trays and everything. So we have our supplies, we have our oxygen, and even to go out in the field when we're doing the vaccine, we have all the supplies ready, just waiting for the start date.
I understand there will be some drive-through facilities as well, but we're going to talk about that tomorrow, just giving them a little bit of a teaser. And tomorrow we're also going to have someone who has had both shots of the vaccine, and we'll see if they look any different, if there's hair going out of their teeth or they're behaving peculiarly, because one hears all of these things about the vaccine. Dr. Ferdinand, you wanted to have the last word from the panel?
We have already begun our training for the teams, and we should finish by Tuesday. So along with what Sister Cook said, I think we're ready. We're working hard on it. We're raring to go.
The health professionals are ready. Are we? We are going to find out pretty soon. Now, tomorrow, as I indicated, we are going to do the second part of this vaccine discussion, the vaccination discussion, COVID-19 vaccination in Barbados. And tomorrow evening, I beg your pardon, either whether we go tomorrow or Tuesday, the focus is going to be on the actual rollout. Who is going to get vaccinated, how it's going to be done, where it's going to be done, more of the logistics. And we hope then to have the other national coordinator, Major David Clark, with us, and another very knowledgeable panel. I think that you would want to join with me in not just thanking, but congratulating this evening's panel for really very excellent information in the face of all that is out there on social media, and really guiding us through this issue of a COVID-19 vaccine. Should I or should I not take it? Normally at the end of the press conference, I give the key points. We're running late and there have been so many great takeaways. I don't know how to begin to give key points this evening, so I'm just going to say to you that the University of the West Indies is recommending that you take the vaccination. The public health specialists are recommending that you take the COVID-19 vaccination. The Ministry of Health and Wellness is getting prepared to give you the COVID-19 vaccination. The nurses, our public health nurses, are ready. They are not just saying, take it. They're ready to give the shot and to take it themselves. But until we have our vaccination, we have to continue following the protocols. Wash our hands regularly with soap and water or use sanitizer. Wear our masks correctly. Move away 6 feet at least from strangers, people we don't know, and even with family members and in the context of our homes, particularly around the elderly and those who may suffer from chronic non-communicable diseases, sugar pressure, and so on. Wear your mask, exercise care and caution, and of course, if you or any one of your family starts to feel unwell, if you have flu-like symptoms, things that you might think are allergies, if you start to get bad feels and you can't feel better, a dry cough, do not wait, do not hesitate, do not stay ill at home. Our doctors and nurses are prepared to help you. Get help immediately. Don't wait until it's too late and you can't be helped. And certainly don't wait until you make a loved one ill. On this day, when we pause to pray during our national pause, as we contemplate the issues and seek to come to grips with how we can protect each other and our nation from COVID-19, may God bless us all. Good evening to you.